So this is truly in keeping with this being a World Congress. This is truly an international panel here, and I'll just introduce very quickly. Amy Chen is the Director of Head and Neck Endocrine Surgery down at Emory. James Burley heads up the radiation oncology up at Princess Margaret, and in Toronto. Dana Hartle is Chief of the Thyroid Surgery Unit at Gustave Roussy Cancer Institute in Paris. Henning Drahl is a Professor of Surgery and Head of the Department of Surgery at Hospital Essen in Germany. And so this is truly a distinguished panel rounded out by Joseph Scharf, who is Director of Head and Neck Endocrine Surgery at the Cleveland Clinic. And so this is really a unique opportunity to have these folks weigh in on some of the controversies related to the management of this aspect of thyroid cancer. And what I hope to cover in this panel is some of the pretreatment workup in patients with invasive cancer, surgical decision-making, and some of the nuances as it relates to surgical technique. And Jim, I'm going to really pound you for some of those topics here.
Thank you.
Role and approach to primary and adjuvant radiation therapy, and in keeping with the fact that we've got 4 surgeons and 1 radiation oncologist, I'm going to try to get 4 times as many questions to Jim to make up for that. So that's how we'll keep this on an even par. Approach to management of recurrence and management of complications. And so the goal here is to get expert clarification, and as the mandate was that we try to keep this as much case-based as possible. So just a few points to get started here. Some of the challenges associated with this disease is related to the rarity of this disease, and it therefore does not lend itself to randomized prospective control studies. Increasing incidence of early stage disease of thyroid cancer really has lulled many surgeons into a level of complacency, and often are caught off guard when they open up the neck and find that they're dealing with a little bit more than what they are used to dealing with. And there's very little, I think, with respect to our national clinical practice guidelines, with respect to some of the details on how best to manage this. And so this is a slide that you've seen 100 times, if not more, showing what's happened over time. But the interesting thing, which really relates to this specific topic, is this great declining incidence of invasive disease as it relates to the total volume of thyroid cancers being managed, and hence some of the challenge. And so we'll start off with a definition here of what constitutes invasive thyroid cancer, and it refers to any extension of disease outside of the thyroid gland or outside of a metastatic node manifesting extranodal extension. And just to digress for 1 second here, Dr. McCaffrey, over 2 decades ago, clarified for us what some of the routes of entry of thyroid cancer are into the upper air digestive tract, and we'll come back to that a little bit later on as it relates to surgical management. And just for those of you who haven't quite seen this yet, what's going to happen in the 2018 8th edition of the AJCC staging is that there will be a subdivision of T3, where T3B will include gross extrathyroidal extension into the strap muscles listed there. T4A will be invasion into the larynx, trachea, and esophagus, or the recurrent laryngeal nerve for any tumor size. T4B pretty much remains the same here. And so most of what we will be talking about is T4B disease, and so that's what we'll be exploring here. But there is another way for us to break down the T4B staging. And this was highlighted actually from Shin et al. Many years ago, in which he looked at the stages of tracheal invasion and divided this into stage 1, which he categorized as invasion to the perichondrium, but no cartilage erosion. And he had 22 cases of that early stage involvement. And then stage 2 was invasion between the rings, as shown in the illustration. Stage 3 was extending through the cartilage, but not into the actual lumen. And then stage 4 was invasion within the lumen of the trachea. And there was a clear distinction with respect to how patients in stage 1, 2, and 3 fared as a result of their therapy as opposed to stage 4. As you can see there, patients in stage 5 had a much greater likelihood of dying of their disease, as well as having positive resection margins, as well as a much greater incidence of lymph node involvement. And this was further validated by the Japanese, who have, in a study by Hotami, who added what is EX3, which is essentially a Shin stage 4, in which there was invasion of the tracheal mucosa and or esophageal mucosa, and this really seemed to break out with respect to the parameters that we look at for outcomes. And so with that as a framework, let's get to where we are today here. So let's explore a little bit about what the guidelines tell us about initial evaluation. And cross-sectional imaging does play a role in a patient in whom you suspect that they have invasive disease. And either CT or MRI, CT with IV contrast. And so I'd just like to explore with the panel, what's their imaging modality of choice? Amy, do you want to start us off if you think you've got somebody with more advanced disease?
I like to start out with a CT with IV contrast of those 3 options there. I think it gives us a good idea of not only the soft tissue, but also the trachea and the cartilaginous and bony structures in the neck.
Okay. Dana, do you same choice here? Or do
yeah, CT with contrast, neck and chest. And you want to go up higher too. If you've got patients with bulky lymph nodes, then you want to be looking for retro-pharyngeal nodes as well. And then if you've got, for the esophagus and things like that, I would go maybe to other kinds of imaging like invasive endoscopic ultrasound of the esophagus. If I have a doubt about the esophagus, that's something that we would do.
Okay. What do you Henning?
In Germany, the computed tomography with contrast agent is not recommended due to the potential delay for radioiodine treatment, so that is at least the recommendation in Germany.
So do you go directly to MRI?
We would do MRI, yes.
I see. Okay. All right.
So can I say something about that? I mean, I think, in the era of modern contrast, you only really need a month before it's cleared and giving radioactive iodine. And certainly in our experience, by the time the patient had the CT and had the surgery and recovered, there's plenty of time to get rid of all the contrast. So in our institution, IV contrast with CT is what we do.
Okay.
Or is done.
All right. Terrific. And as far as PET imaging, this is what the guidelines provide us for guidance. When do you, as a panel, pull the trigger and decide to get a PET? Do you have any, Joe, do you have any thoughts on this?
Yeah, usually it is in the setting that's listed when you have an increasing thyroglobulin and you're not able to localize structural disease for a patient. On initial presentation, though, I often don't use PET imaging routinely.
Okay. Panel, do you, in a patient, as part of your initial workup in the primary setting, will you all, is there a time when you might go to get a PET as part of the initial evaluation?
I think we kind of have a low threshold for PET. It's not systematic, but if we're a little bit worried about maybe distant metastases, we know that this is something that's aggressive histologically. We've got, tall cell or even poorly differentiated disease. We're probably going to go to an initial PET.
Okay. All right. So let's get to one last preoperative assessment tool, and that's endoscopic evaluation of the trachea or esophagus, with or without ultrasound, as Dana mentioned, at the beginning of the initial operation. So I really want to explore this a little bit. What role, Joe, does it play in a patient as it relates to information that you get from the scan and information that you get from office fiber optic laryngoscopy? What more do you get?
Yeah, no, the endoscopy is crucial. You just never want to be caught unaware, and we'll often do this not necessarily even in the OR, but we'll do it in the clinic, locally anesthetize the trachea and look down the trachea in the clinic, take pictures, and we could forward that even to our anesthesiologist before they go to intubate a patient. Those issues are so important ahead of time.
So if you don't see invasion of the trachea, what are you looking for?
Yeah. So you're certainly looking for the mobility of the vocal cords to give some indication whether there's compromise of the recurrent nerve. Even if you don't see a gross invasion, you can see subtle vascularity or submucosal bulging that might give you more of an indication that there is true tracheal invasion, even though it's not a full intraluminal bloody mass. So those are very important. Esophagoscopy, we'll often do in the clinic as well with transnasal esophagoscopy or in the OR, looking for those.
So how often in the asymptomatic patient who is not complaining of swallowing dysfunction, how often will you actually see something on esophagoscopy that changes the way you approach that patient?
Mm-hmm. So on esophagoscopy, not that commonly, because usually the invasion is limited just to the muscular layer, so you don't often see a transluminal invasion through the into the submucosa and mucosa. So that'd be a very rare event, actually, to see something on esophagoscopy, that is.
Amy, do you do both direct laryngoscopy, tracheoscopy, and esophagoscopy on all these patients?
Usually do indirect laryngoscopy in the clinic, as Joe mentioned. I think it's very useful for documenting the airway and for looking at subglottic extension. I think tracheoscopy is also something that can be done. Esophagoscopy we do not do in the outpatient setting in the clinic. However, we can do that if I'm highly suspicious based on cross-sectional imaging at the time of the surgery. The other thing I like to do is to put in a bougie into the esophagus for these more advanced thyroid cancer cases, so that I know where it is, so when I can take off the muscularis layer with hopefully not penetrating the mucosal layer of the esophagus and causing a fistula. But I think these are very important steps for planning surgery and for deciding whether a tracheal resection is necessary, for example, or some sort of reconstruction for the esophagus.
Okay, so let's get away a little bit from the didactic and try to put that workup in play here. And this is a 73-year-old female who presented to an outside emergency room with some respiratory difficulties. She said this had been coming on over the course of a few months. She was felt to have some noisy breathing and was treated for presumptive asthma. Her symptoms, she left the emergency room, her symptoms persisted, and she went to see her primary care physician, who escalated her asthma medications, and then finally, when her symptoms persisted, she got a CT scan. And this is what the scan showed. So when I saw the patient, she had really reasonably significant biphasic stridor. She had minimal hoarseness, and physical exam was really otherwise unremarkable. And so, Dana, what are you thinking when you see this scan here?
Well, it looks like there's pretty much obvious tracheal invasion, excuse me, from the thyroid tumor. I would definitely want to get a tracheoscopy on that to see the posterior wall, because on that left-hand image, it looks like it's very posterior, and that would really affect the surgical approach.
So, Henning?
Yeah, I agree. That is definitely the patient we would do a tracheoscopy and esophagoscopy probably as well.
Okay.
Yeah.
So in the office, and I apologize, this is not the best imaging, but I'll just highlight this. This is what I saw. Her cords were fully mobile. Are you going to get more information from doing tracheoscopy in the operating room setting, or if I was able to pass the scope beyond this and saw that she had normal tracheal below? Do we need to take her to the OR for that? Is that going to really be additive compared to what her image showed?
I don't think so. I think that your cross-sectional imaging and your endoscopy in the office will give you an idea of the length of involvement and how much you need to take.
Okay. So what are the next steps in this patient's workup? Where do we go with this? Does she need any further imaging, or do we go directly to surgery here? Joe, what do you think?
Sure, definitely. As we discussed earlier, I think further imaging to make sure you have the chest included, a distant metastatic workup, and you need to secure the diagnosis too. So a needle biopsy to try to confirm the diagnosis would be very helpful.
All right. So imaging the chest was completely negative. Dana, any further thoughts here? Do you go to surgery at this point?
I think I'd want a biopsy of the tumor, not just, FNA. Maybe endoscopically, because there is tumor in the trachea, that's the most accessible, so she would probably have that. That would be an outpatient. I wouldn't do it myself. Well, maybe, sometimes I would, but if she could do it, they could probably do it just as a day thing, and there are pneumologists would do that. But then you'd actually have pathology.
Okay. So we did send her for ultrasound, and ultrasonographer could not identify a mass on that right side. And I was concerned that maybe this was in an inopportune position due to it being more posterior. But the ultrasonographer did identify an 8mm nodule on the contralateral side, which looked suspicious and was biopsied and was felt to be a micromedullary carcinoma, 8mm. And she had a calcitonin of 42 and a CEA of 30. So where do we go from here? Henning, are you ready to go to surgery?
So the tumor on the right was?
Could not see it on ultrasound. Could not identify a mass on the side where the CT showed a mass.
That's strange.
That's what I thought. All right, so
But that would be the reason, of course, to try to get a biopsy from the tracheoscopy to identify clearly the lesion, the nature of that lesion.
Okay,
because
so
that would be really strange if that is a metastasis of this 8mm MTC.
Okay, so I couldn't quite put this all together, and I did get an MRI, which seemed to show a slightly different picture. And at this point, I did take her to the operating room, and she had a smooth mass arising exactly where you saw it on the preoperative fiber optic laryngoscopy. And the biopsy came back as normal thyroid tissue.
Oh my gosh.
All right, so what do I do now for this patient? Amy, where would you go with this?
Strange.
Call Dr. Erkin. No. I think I would try to get more tissue.
Yeah, so I did. I didn't believe the frozen section, and I just kept getting more tissue, and the frozen just kept coming back as normal thyroid tissue. And
no follicular thyroid cancer. No,
what's that?
No follicular thyroid cancer.
Well, that was still a question.
Yeah.
That was still a question.
You can get benign rests in the thyroid.
Yep.
I certainly have seen those with normal tissue.
Yeah, absolutely. So I've been fooled on that before, and seemingly I was set up to be fooled again here. And so just for the sake of taking this one step further, I did do a total thyroidectomy and a central compartment lymph node dissection, probably a little bit overkill for this 8mm medullary thyroid cancer, and I did laser debulk that tracheal mass, which did on final path turn out to be benign thyroid tissue. And she had a medullary carcinoma in the left lobe, was 8mm, and the right lobe showed a microcarcinoma, papillary and normal intraluminal thyroid tissue. So does she need anything further? And how would you manage that residual tracheal mass moving forward. I didn't do a complete resection. Does she need a complete resection of that?
So what did the tracheal wall look like from the external portion of the trachea?
Tracheal wall looked absolutely normal. Yeah.
So there was no growth from extra to intra,
Now, the CT.
because
really-
that was,
Yeah, CT
Suspected.
really took me down the wrong pathway, but the MRI was a little bit
Yeah.
more forgiving here. So not sure what to make of that. I was stumped by this one as well. Do we need to do a resection of the trachea to get rid of this? I didn't do a complete resection of this thyroid rest here.
How is she breathing post-op?
Airway's much improved. Anything,
I don't
Joe?
think, I mean, it's symptomatic. You could look to maybe suppress, just like if you had an enlarged frame and cecum, thyroglossal cyst, just to keep it from symptomatically under control.
Yeah, so that's the direction that we've taken this, and so far so good. So let's move on for a little bit.
So I've got to start paying attention now.
Yeah, exactly, Jim. So here's the deal. I really want to get some clarity from Jim as to when we should be thinking about external beam, and as we go through the cases that follow, I'm going to keep coming back to you with that. In 2009, recommendation 41 said that we should use external beam to treat the primary tumor. Should be considered in patients over age 45 with grossly visible extrathyroidal extension at the time of surgery and a high likelihood of microscopic residual disease, and for patients with gross residual tumor in whom further surgery or radioactive iodine would likely be ineffective. The sequence of external beam and RAI depends on the volume of gross residual disease and the likelihood of the tumor being radioresponsive. And then just to move forward, in 2015, the only recommendation related to EBRT was this, that there was no role for routine adjuvant external beam to the neck in patients with differentiated thyroid cancer after initial complete surgical removal of the tumor. And then the narrative pretty much filled in the blanks here. That was in keeping with the 2009 recommendation. So Jim, give me your thoughts on when should we think about using external beam? What do you do in practice when a patient gets referred to you for consideration? Are these good guidelines for us?
Yeah, I mean, I think the 2009 sort of reflects our own policy. I mean, the main difference is age. I mean, I think use of 45 was used because that was in the current T&M guidelines at the time, but I think we all think that 45 is too young a cutoff for poor prognosis, and we use 55, and that's actually what the 8th edition is using. But I mean, I think there's nothing magical about age. Age is just a continuum, and so it depends on the extent of disease. I always think it's very important to discuss with the surgeon what the tumor looked like when they resected it, what the likelihood is of microscopic or macroscopic diseases, and what's their willingness to go back into the neck again if the patient recurs. So I think it's something that requires a multidisciplinary approach. But I think external beam radiotherapy is very important in maximizing local control in the neck and prevent the dreadful problems that occur with unresectable recurrent disease.
Okay.
And I must admit there is the American Head and Neck Society guidelines last year, which I think reflects this approach.
Yeah, those. Yeah, I was going to show those, but they really are pretty much in keeping with.
They're all in keeping. They're all similar.
Henning, do you? What's your threshold for referring a patient for external beam?
We have been all the years very, very restrictive to recommend EBRT. So even in the case of R1, so histological incomplete resection, we would wait for recurrence and then try to resect, perhaps even a second or a third time. So we call that sequential surgery. Sometimes also the patient is coming to our department for a second surgery, not we having done the primary surgery. So especially in that case, the situation is sometimes difficult to assess. And at the end, we follow this sequential surgery. Until that point, there are no further surgical options, either with regard to a solitary lesion, which is not surgical curable or resectable, or in the case the patient has so many multiple tumor foci that there is no access to come over with this sequential surgery. So at the very, very end, of course, then we would also see an indication for EBRT.
Okay. Dana, do you have any other thoughts on this when you recommend?
Yeah, well, these are always, discussed in the tumor board, of course. And we would also, it's a good point, is I get asked, if it recurs, would you go back? Could you go back? Because once the radiation is done, you're less inclined to go back surgically because of the complications. And we also look at pathology. We maybe have a lower threshold for poorly differentiated cancer. And then we look at, of course, age. And we look at also if it's recurrent disease, if it's something that's recurred really quickly, or if it's something that had been operated on 10 years ago and now it's a recurrence. So that's maybe if you're thinking that it's recurring and recurring, maybe we're going to go toward radiation therapy.
So time from treatment to recurrence plays a role here. We're going to come back to that, but I think that's a really excellent point here. So let me get to a case here. This is a 69-year-old female, otherwise healthy, who developed a chronic cough and was worked up initially with a chest x-ray, and a lung nodule was identified, and of course that led to a PET CT, and then a biopsy of the lung nodule revealed a carcinoid tumor. But she also had some findings in the neck. As you can see here, she had uptake in the thyroid, she had some lateral compartment, and she also had a lesion in the retro-pharynx. And so I did get an ultrasound-guided FNA of the thyroid, which showed papillary thyroid cancer, as well as a positive biopsy from level 4 that was also PTC. There was significant FDG uptake in this retro-pharyngeal mass with an SUV of 10.7. And so what would you do now? She's sort of put on hold treatment of the carcinoid. So where do we go from here in the workup of or treatment of this patient? Henning?
Could you explain a little bit more the term carcinoid in that point? So it was calcitonin negative completely, or?
That's correct. Yeah, this appeared to be a separate low-grade carcinoid tumor, unrelated to what we were seeing in the neck here. Joe, what do you think?
So you've done quite a bit of imaging. She's had a full ultrasound. We have biopsy-proven disease. Certainly consideration for surgery is in order, which would include probably a total thyroidectomy, central neck dissection, even a lateral neck dissection I consider, which would give you also at the same time access to that retro-pharyngeal node with the overarching, theme and concern of getting local regional control for this situation.
Would you need Amy, would you want a biopsy of that retropharyngeal mass before going ahead with that?
I don't think so.
No? You think it's high likelihood this is related to the
PTC.
PTC?
Yes.
All right. So I did do that. She was very adamant about not doing anything more aggressive with respect to getting access to this to the retropharynx. But what I did find is that she had significant local disease in the central and lateral compartment. As you can see here, she did have some adverse histologic features. And what I found when I was approaching the retropharynx is that this tumor was fixed to the carotid artery, the internal carotid. And I didn't think it was safe coming from a transcervical approach to be able to mobilize that further. And so I did do a more limited resection, basically debulk that disease. And so what do I do at this point? Dana, would you try to convince her to get greater exposure to the retropharynx through a more extensive approach? Would you do a mandibulotomy and take that approach here?
Do you have an MRI on that? I would get MRIs on all of those. I like having CT and MRI because you see the soft tissue in the retro-pharyngeal area. I feel I do in the MRI better. But you couldn't find a dissection plane with the carotid artery?
No, and I didn't.
So maybe it's not resectable.
I didn't have distal control from below here. So how do I guide this patient?
How do you, I'm sorry?
How would I guide this patient?
Guide this patient. Maybe some adjuvant therapy in terms of she hasn't had radioactive iodine yet. See if it's iodine avid, because it's PET avid, but maybe there's you might have some effect with radioactive iodine on this.
Likelihood in light of what you're seeing on final path that she's going to have uptake?
We'd try it anyway, I think.
Oh, okay.
At least.
All right.
At least, and then we know that she's refractory. And we actually have proof that she's iodine refractory, but.
All right, Jim.
Yeah, I would agree. I mean, I don't think there's anything lost by giving radioactive iodine and see what happens. And then watch the node one way or the other.
Joe?
Yeah, these tall cell variants, I have such little optimism about them taking up radioactive iodine. Then I worry as they progress with gross disease, the morbidity that you may be facing. I might often consider trying to encourage an IMRT approach for radiation early on in a patient like this.
Okay.
Because you debulked it, but it's minimal or microscopic almost disease.
Well, this was really an artery resection. There was, the last thing I wanted to do was to go. Jim, so if I send her to you, are you going to say, give her radioactive iodine at this point?
I think so. I mean, as I said, it depends whether you want to rush in and treat now, or whether you think it'd be appropriate to wait and observe. I mean, I think first thing I would do after surgery is do a CT scan or an MR and assess the extent of residual disease. If there's no immediate concern about the local effect of the tumor, then I would watch and then approach it as necessary. I mean, if she's really got true tall cell and she may develop metastatic disease and this retro-pharyngeal node may not end up being of significance for her. Or you could go ahead with external beam radiotherapy now.
Okay. So I did, and this was one of those, yeah, Henning?
Perhaps a step before, did you talk with the pathologist?
Sure.
Because I'm thinking about this difference between carcinoid and tall cell, because I couldn't imagine how that comes together. Because when perhaps because in that situation perhaps I would have done only a lobectomy and removal of this retro-pharyngeal node. Perhaps with frozen section, then I would know that this is a tall cell variant. But only with this information carcinoid, I wouldn't do a total thyroidectomy and central node dissection in such a very, very rare case.
So I'm not sure how, I was looking at these as two independent processes going on in the same patient here. I'm not sure that one really was influencing the other. Joe, do you have thoughts on this?
One other thought, though. It may not be unreasonable at this point to engage your neurointerventional colleagues and see what her collateral blood flow is here. If this were to progress, what are the implications? That might, give you some kind of thought process about how aggressive to be if you ever had to sacrifice that artery.
And my other thought, too, is to see the thyroglobulin. If you know you have gross disease that's left behind, if her thyroglobulin is very, very low, then it's likely that she's not going to have an iodine-sensitive tumor. And I might be more inclined to offer radiation first. But I think I would agree that we would probably offer radioactive iodine first before we went to EBRT.
All right.
Yeah.
So, Jim, I've already asked you about this, but if by chance I twisted your arm.
If you twisted my arm, I would probably just treat the local disease. I mean, the rest of the disease, there's no extrathyroid extension, there was no other extranodal extension of nodes, and you're adding significantly to the toxicity of the radiation by treating the whole thyroid bed and nodal bed. I would just treat the retropharynx and...
Okay. So we did give We did give radioactive iodine as a whole body scan, and there was no uptake either in the either at the retro-pharyngeal. She had a small thyroid remnant as expected. We've been following her now, but really gets back to Joe's point of what do we do if that's been stable now for about 9 months, I think. If this starts to grow, the residual based on MR imaging, you'd go down a pathway here of a more aggressive approach surgically. Joe?
You may need to, because as if you read the book before the pages are turned here, she may have compromise of that artery and neurologic sequelae from it. So engaging some of the neurointerventional physicians, even some of your vascular colleagues, may be in order to think about.
Okay.
Yeah.
All right, so let's move on a little bit here and get to some of the more pragmatic issues related to the management of the trachea and larynx that's involved by tumor. And this is the goals as stated in 2015 that we should try to remove the primary tumor, clinically significant nodes, and achieve a complete surgical resection. And recommendation 72, when technically feasible, we should address the upper air digestive tract, invasive disease, and then combine that with radioactive iodine. It does, the narrative does give us quite a bit of wiggle room here in terms of what constitutes appropriate extent of surgery. And so I want to explore that a little bit, but the last line of the narrative says that surgical decision-making can be complex and must balance oncologic surgical completeness with preservation of function. So there are a number of different guidelines that relate to this and how aggressive we should be based on different disease processes, and we're going to come back to that a little bit. These are the guidelines that have addressed this, and basically the threshold, the fundamental principles are how aggressive should you be based on the impact of the radicality and as it relates to the patient's quality of life, how it would impact on persistent recurrent, how persistent or recurrent disease would impact on the quality of life and survival benefit. And so if I could just have the panel just briefly, Amy, how does histology affect how radical you're going to be in the operating room?
I think histology does have a large impact. Obviously, the more aggressive histology, such as poorly differentiated or anaplastic or medullary, would make me more inclined to offer a more aggressive surgery. But I think the most important discussion that the surgeon should have is with the patient and with the family. Some of these resections that we do can be very, very impactful on their lives, especially if they are illiterate, for example, or they already have some severe comorbidities and poor functional status. So clearly we don't want to prolong life, but then have a severe detriment to their quality of their life or their function of their life. And I do think also consideration of whether securing the airway with a trach is necessary in order to get the patient through the treatment. So if we do less than total resection of the tumor, will the patient be dependent upon a trach and a peg after the surgery? If that's the case, then perhaps we should be offering a different surgery, because that's clearly not a great way to function after resection. So I do think that discussion with the patient and with the family is the crux of where I would go with how I would manage these locally invasive disease.
Okay, I think that's a great summary here. And this is just from the MTC guidelines that really state this very well and just highlight the fact that these decisions are best made by experienced multidisciplinary treatment teams. So with that in mind, let's get into a few cases, and I really want to get to the inside the panel's heads here in terms of how they make these decisions in the operating room. So this is a 78-year-old female with a history of bilateral breast cancer, is treated with surgery back in 2006, and then she underwent in 2006 follow-up PET imaging, and the PET scan identified a hypermetabolic 4-centimeter thyroid mass, and it was biopsied and confirmed to be PTC. She did have some small FDG avid nodules in the lung. As you can see here, one of them had a small amount of uptake, but these were really not clear. And so this is what our preoperative imaging demonstrated. And prior to coming to me, she did undergo, the biopsy confirmed papillary thyroid cancer. She underwent surgery at an outside facility, and at the time of that surgery, the thyroid was exposed and found to be invading into the tracheal wall. And 5 days later, I saw the patient, and she was healing well at that time. She had no evidence of infection. The left cord appeared to be immobile, and pathology did confirm papillary thyroid cancer. So where do we go from here? Dana, would you biopsy the lung? And what would the rest of your workup look like? Would the lung biopsy affect your treatment plan here?
Can you show that CT again, please? Or the PET or whatever, the imaging before? Can you
Yeah.
go back? Okay. The lung, oh, that little thing. No, yeah, I'm not sure that we could biopsy that. That's a small one. No, and I think it probably goes with it, so no, I wouldn't biopsy the lung. The previous surgery was just open and close.
Open and close.
So she still has that disease. It's a tough call. You might want to look at the trachea endoscopically, maybe look at the esophagus with ultrasound, endoscopic ultrasound, know a little bit more about the resectability of this and the outcomes of a resection, if you can do a sleeve resection or something like that. So I would maybe stop and take some time and do a little bit more endoscopy.
Okay, all right. How does, Henning, does the prior surgery affect your approach here? Would you wait for a period of time in light of the previous approach, or does that not really affect your decision-making here?
Okay, I think these are the two alternatives, to wait and use the time for a little bit more diagnostics perhaps, or to do the completion or the operation in the neck, try to remove the thyroid in total, including the left side, by at least shaving, so to permit radioiodine diagnostics, and that would be perhaps the other option. At the end, I would decide that together with the patient, to look at the patient. Is he fit for such a procedure?
Yeah, she's otherwise in good health.
So I would tend to that alternative.
Okay, so we did wait for a little bit of time in order to let things settle down, and we went to the operating room, and this is where we are at. So you can see here we've got a mass, and we've got some changes in the tracheal wall, and that are evident here, and you can see just for orientation purposes. So what are the intraoperative decisions that you're going to make here, Joe, as you're approaching this? How would you handle this particular case?
Right. So certainly, as the other colleagues have said, before the case even starts, you've had a long conversation to go over these options. And if you're looking to have a completeness of resection here, trying to identify about how much of that trachea would need to be resected, if that's your goal, is important. It looks like it extends not terribly inferiorly. So you can certainly start to mobilize some of that trachea inferiorly. Usually on some of these cases, I may even have a thoracic colleague on board in case we needed them. But you'd want to really define the extent of how much of that trachea would have to come out. Usually could take about 4 centimeters, sometimes a bit more, depending on the elasticity of the trachea and how much tension. You don't want to put tension on your closure.
So how do you make this decision of whether or not to peel this off the trachea? If you're seeing these changes in the trachea in the cartilage here, we didn't see intraluminal extension, and tracheoscopy didn't show what I thought was any evidence of involvement of the mucosa here. So Henning, would you do what would your approach be? Would you do a shave resection here? Would you do a window resection, a sleeve resection? How would you approach this, and how do you decide?
I wouldn't do a segmental resection when this procedure has not been discussed with the patient
Oh,
before.
no, this has been
So,
discussed.
Of
So
course,
she
yeah,
came in-
but
yeah.
this, I think this is an integral part of the
Sure.
intraoperative decision-making, and perhaps in such a extensive, and 4 centimeter or a little bit more would be, I think, a situation in a 70-year-old patient. You always has to think upon the next step, and the next step, I think, includes a complication when you have done a segmental resection. So at the end, I think, I do not know. I cannot say that from the table. Perhaps I would prefer a shaving procedure in that situation.
So if you're leaving what appears to be tumor on the wall of the trachea, would you be comfortable with that in this setting?
Comfortable, of course not, but it's a decision-making between what the patient can tolerate and what perhaps can tolerate the patient if a complication occurs.
Okay, all right, so,
So,
yeah, Amy?
One thing I wanted to bring up is the previous surgery may be discoloring our information here. This could be scar tissue. It's not clear whether this is malignancy. I would shave and then do a frozen section and see if this is truly a malignancy.
It's positive. Came back positive on
Yeah,
frozen.
which is not a surprise. But since there's no intraluminal invasion of the trachea, I don't think I would do a segmental resection.
Joe, are you on the same boat here?
You know, this is complex because one of the things we haven't talked about is we're dealing with a solitary nerve now, and I don't think that nerve was compromised from the prior surgery, but rather from her tumor burden
I
here.
think that's correct.
And so before you do a segmental resection, which would usually be my preference for many of these cases, I'd want to make sure that nerve with nerve monitoring is intact and been protected, because if you do that and put anastomosis there, that could be a life-threatening event afterwards for the patient. But I just worry about doing a shave resection here and still maintaining control of the disease process, even with external beam radiation, if she was unwilling to undergo a tracheal resection.
Yeah, so it was one of those
But there are
discussions.
lung metastases.
Well, we don't know. Those lung nodules hadn't been characterized. We assume they probably are. They were not hypermetabolic here.
And it's classic papillary?
It appeared to be based on, again, so that's what the appearance was.
And to tag along what Joe just said, I think it's important to know where you are in relation to the cricoid. Because if you have to take the cricoid as part of your resection, that's really going to compromise your nerve integrity.
Well, that side's out already.
No, on the
On the
contralateral
opposite side. Okay, all right. How many people in the audience would do a shave resection in this setting? How many would do a sleeve resection?
Segmental.
How many would create a window and stay off the other side? A few. Okay. All right. Terrific. All right. So there is some guidance in terms of what the extent of disease, both in a longitudinal and in a circumferential, from the work that Ozaki published in the past. And basically, as a surgeon, you're looking from the outside in at the wall of the trachea, and what they found was that we usually are pretty good at identifying what the longitudinal extent of the disease is, but often will come up short in terms of extension more along the inside of the tracheal lumen. So with that in mind, does that play a role here? And how do margins impact your decision-making when it comes to thinking you've completed your task here? Joe, do you get margins in the operating room?
Yeah, I actually take a lot of margins in these cases. A lot of times we'll see them sometimes in the reoperative setting, which makes it even more difficult if you've never been there for the original surgery, but absolutely, because you're battling with scar, as Amy had said. But I take an awful lot of frozen sections in these things to kind of ensure the completeness of resection. Sometimes you can't get a wide margin or a wide margin-free resection, but you want to get as much information you can about the completeness of your resection.
Okay. All right. I'm a little bit perplexed by the decision to shave here, with this wall being as seemingly involved as it is, and inviting, you've got your best shot at this point in time compared to coming back at a later date here. Do you guys want to defend that a little bit?
I think that, I don't think that we're losing anything by giving her a shot. She's 73 years old, and I think that and I can't really tell how much, I mean, if it starts at the second tracheal ring and goes inferiorly, or whether it goes all the way up into the cricoid. I mean, if I make a window and I peek in there and I take a biopsy of that mucosal layer of the trachea and it's positive all the way up at the cricoid, I'm not sure I'm going to be able to clear this without doing more than just a tracheal resection. And so I think that I would be willing to give her the benefit of the doubt and try some other, and give her maybe, and then have another discussion with her and say, listen, if we go back in there and the mucosal margin is still positive superiorly into your subglottic region, I haven't really done anything to help her if I had already done a tracheal resection at the outset.
Okay, all right. So here I am. I didn't have the panel to consult, and this is what I've done. And you can see some of the changes that I didn't appreciate at the time of the tracheoscopy that are evident on the mucosal surface here. And so, Henning, this is from your work. I assume this is type 4. And any thoughts here in terms of where to go with this? A simple tracheal repair, and then you'd recommend putting sternocleidomastoid muscle over the suture line. Am I correct?
Technically, of course, it's the easiest type of tracheal resection, and of course, this has to be included into the entire concept with the patient and the comorbidity and all these things, lung metastasis, small ones, treatable radioiodine tumor, and so. But from the technical point of view, it's a relatively easy type of surgery, and when you have a good anastomosis, you don't need any support by SCM.
Oh, okay. So we did go up just to the took a little bit of the bottom of the cricoid on that side. We came off the cricoid. The nerve on the opposite side was well lateralized. And so this is what things look like at the completion of this. And what do you do in terms of dead space? Does that worry you at all in this setting? You got a lot of important structures in this area. Aside from SCM, is there anything else that you would add to the equation here? Because if she should leak from this, she's going to have a serious problem here.
Mm-hmm. Usually I try, I mean, this is a rehab situation, but usually that's what I tell my residents, as I really try to keep the sternohyoid muscles, because usually they're often not invaded by the tumor. I mean, they weren't on the CT and all that. So even if they're a little bit fibrotic, you try to keep that anterior part of the muscles that you retract, and that way you can use those to cover your sutures, at least. So usually I sort of try to tack those down onto the suture line when I'm done, and it's kind of keep the suture away from the carotid. But
okay, all right. So let's just explore this, a couple quick technical points so we can move on. How long do you keep your patients intubated after this type of surgery, Henning?
That's a very good question. When this anastomosis is perfect and ideal, I would extubate the patient immediately.
Oh, okay.
Yeah.
Any disagreement?
And of course, if there is no cricoid swelling or more than one recurrent longitudinal nerve palsy.
Right, okay. Joe, do you extubate right away?
Yeah, I always try to extubate right there, and certainly I'm there when they extubate to make sure everything's going well and watching closely. And knowing the status of that other nerve is very important, certainly. And it looked like it was a pretty tension-free anastomosis there. So
yeah, it was. Yeah, the other nerve stimulated well. So I was not. We finished this a little bit later in the evening. I elected to extubate her the next morning in the ICU, and within a couple of hours, she sounded great initially, and then she started to become to tire. And when we looked down, she had a fair amount of edema. The opposite cord was moving well. What do we do now? Do we re-intubate? Do we take her to the OR to trach? If you trach, how do you deal with that circumstance?
So I think one thing you could do is positive pressure, do BiPAP, and see if that helps her in terms of supporting her.
Yeah, she's just not looking great. We tried everything, and conservative, she just wasn't looking great.
Yeah,
if there is no medication or no medical treatment of that edema, we would re-intubate the patient.
And then give her a trial for a period of time and then re-extubate after some time?
Yes,
Yes.
no trach.
No trach?
Yes.
Okay.
Re-intubate, wait for 3-4 days perhaps, and then try to extubate.
In the operating room.
Yeah.
In the OR. Okay. All right. Fair enough. So this is what she looked like down the road. We did get her through, and she did undergo further evaluation. This is her pathology. She was a T4A N1B with focal tall cell features. And how do you go from here with further decision making? How does tall cell features influence you, Jim, in terms of what you recommend for this patient?
Well, it says focal tall cell features, so I assume that means less than 30%, so it shouldn't make any difference to further decision making. Focal tall cell is not a poor prognostic feature. It's when it's more than 30% that it's of concern. So that wouldn't make a difference to my decision making.
So she goes directly to radioactive iodine therapy at this point?
Yeah.
Okay. So she did do that. We did not recommend external beam, and 4 months post-op, this is where she's at and functioning quite well, and we've decided to watch those lung nodules. So let me just move on here. And this is an 82-year-old patient who presented with hoarseness, a large mass in the right thyroid bed, right vocal cord paralysis, and a Konofsky performance scale of score of 80. And this is her imaging study, which demonstrated this large thyroid mass. And I just want to call your attention, well, let me go back here, just to the interface. And what we're seeing is what we thought was involvement of the lumen on the same side there. So thoughts going into management of this patient. Is it similar discussion to the last one, or do things change here?
It seems like her functional status is a little bit worse than the 73-year-old female. Is that correct?
She is a little bit worse. There was a language barrier, but she came in with about 7 of her family members who were all anxious to have something done for her. And they were representing her and wanted to take care of this problem. So Joe, what would you do for this?
Sure. I mean, with that location, I agree, the intraluminal invasion there, and with the cord being immobile, it's probably going right into the esophagus as well there. I'd have to be prepared for that. And if you're going into a surgical resection with the biopsy-proven disease, I'd have that same discussion for a possible tracheal resection, possible esophageal resection, and if you're not ready to do your own repairs, maybe have a reconstructive surgeon available in that scenario.
Okay. All right, so one added mix in this is what we found. The trachea came together very well. Intraoperative frozen sections were absolutely fine, but you can see we've got Big Brother is sitting right next to the anastomosis here. So what do you do with that? Are you comfortable with an SCM flap here, Henning, or do you take further precautions?
So, sorry, but you made a tracheal resection including the adherent esophagus?
The esophagus we took off in a submuscular plane, and
Okay.
And that came off quite well.
I'm confident with that.
So you wouldn't, nothing further as far as protecting those vessels?
No.
Okay. Anyone else? Is everybody else in the audience just, should we put a drain in and call it a day? Okay. Joe, you're comfortable with that?
It is a problematic site if you were to do a problem. I would think about maybe interposing some muscle in there, possibly even alloderm or something, just to give you a little bit of extra time, although putting something like alloderm might kind of be contraindicated. Just you want vascularized tissue to heal down in that area, so I'd probably look for more like muscle or something in that area to interpose.
Okay, so Let me just digress for 1 second. We've talked about taking tumor off the esophagus in a submuscular plane. What do you advise patients as it relates to that? Does that affect, here you are, this is a slightly different case, but if you do that, does this affect their function, Dana? Have you found that patients develop dysphagia?
Actually, no. Usually I keep them postoperatively on like a liquid diet for maybe a week or two if it's a kind of a big resection like that. Usually I try to cover with some strap muscle. Again, I try to keep as much strap muscle as I can oncologically. But no, really, I haven't had, if it's just the esophagus, usually they're okay. If they've got a recurrent nerve, it might be dysphagic because of the recurrent nerve more than the esophagus.
Okay. Henning?
I always will try to re-anastomose the muscle layer. So I had a complication several years ago when I did such a very long, extensive muscular esophageal resection of the muscle and preserving the mucosa. Then it erupted, and I had to do a free jejunal graft to manage that.
Really?
So
Okay.
that is my personal complication
Okay.
several years ago, but this was only in a very long, 10 centimeter long muscle resection of the esophagus. So perhaps this influences my treatment
Yeah.
in the years after that. So I try to re-anastomose the muscle always.
Has any of the...
And then the patients do not have any restrictions regarding oral intake.
There's got to be a limit to how long a distance you can do that over. Will you? Is there a distance that makes that you can accomplish that? Is it 5 centimeters? Obviously not 10 centimeters.
I never would let the mucosa without any coverage.
Really? Okay.
And when that is not possible by the esophagus itself, I would use the SCM.
Okay. Joe, do you have anything to add here?
We often put adynamic tissue there all the time with free flap reconstructions, and the patients do swallow well. I always keep wondering that I'm going to get kind of almost a Zenker diverticulum. I have put swallow studies on some patients, and they haven't really had difficulty with that. I haven't seen that Zenker kind of phenomenon going on.
Okay, that's interesting. All right. That's been my experience as well, but my question for the panel is, have you ever seen a patient recur at the level of the esophagus as after you've had a clean plane between the muscle and the submucosa? Do you feel good oncologically about that resection plane?
I generally don't. I mean, for many of these, they're in the reoperative setting once again, and often the next step may be an organ preservation loss. So a lot of the patients, I'm thinking about almost external beam radiation in some of those when they have this situation.
So if you get a clean plane and you'll go ahead and commit to external beam?
Well, there's a clean plane usually in the center of the esophagus, but sometimes it's coming right onto the trachea or deeper into other areas that isn't quite as clean in those reoperative settings, certainly where there's been scar from prior surgeons.
Okay, all right. So let me get back to this patient. What I did do is I did bring in SCM and provided coverage. This is her final pathology report here, which reflects significant nodal disease, extranodal extension, vascular invasion. Jim, would you radiate this patient?
Well, I've talked to you, or if it was Joe's did the operation, I'd talk to him first and talk about what you think the plane was like. Look at the pathology, obviously, and the margins are all clear. But if you think you did a good oncological procedure, then I wouldn't. But if you have concerns about margins and the concerns about recurrence, then I would. So I think it's very important as radiation oncologists to know the surgeon you're working with and to talk to them about what they found at the time of surgery. I find operative reports sometimes very difficult to interpret.
Okay.
So the personal one-to-one communication is very important.
All right. How many of the panelists would advise external beam in that setting?
I'd engage the discussion.
You'd start the discussion?
And haven't seen independently. Yeah.
Okay, all right.
Did you resected a nerve?
The nerve went, yes,
Yeah,
absolutely.
so she's if you do radiation therapy, she might have some swallowing issues, or she might have more swallowing issues. She's elderly, and so I would think a lot about the functional implications of radiation therapy in that.
Yeah, we're going to come back to that issue in just a minute, but that's an extremely important point, Dana. So let me show you another patient here that's going to be an extension along this. This is a patient who in 2000, who's a 67-year-old male, biopsy-proven recurrent papillary thyroid carcinoma in the left thyroid bed, underwent a total thyroidectomy back in September of 2013, and at that time, the surgeon described extensive adhesions from a prior parathyroidectomy. It was a 3.5 centimeter papillary thyroid carcinoma with ETE, endoskeletal muscle, positive margins, LVI, and 1 negative node. And the patient did undergo 171 millicuries of radioactive iodine. There was intense tracer localization in the thyroid bed at that time, and an ultrasound in 2014 showed a mass measuring at maximum diameter 1.7 centimeters, and there were rising TG levels at that time and a positive PET that was consistent with recurrent disease. Here you can see the thyroglobulin levels along the way there, and the decision at that time was to go ahead in 2014 with surgery, and in reviewing the operative note from March 2014, the surgeon described that the left thyroid bed tumor was adherent to the thyroid cartilage. The tumor was stripped off the thyroid cartilage and was involving the muscularis layer of the upper esophagus. Mass was adherent to the upper trachea, and pathology was consistent with the original. And the patient and family reported that the surgeon said, "Don't ever let anyone operate on you as it relates to your thyroid ever again." And so in April of 2014, the patient had 197 millicuries of radioactive iodine. And then that was 2014. They did identify recurrent disease along the way that they chose to listen to the prior surgeon's recommendation, and got a follow-up PET, and this is what they found. But importantly, the patient now had developed hoarseness and significant functional impairment of his voice with an obvious paralyzed cord. And this is his PET-CT scan, which shows multifocal involvement in a variety of locations, including the paratracheal, paraesophageal region here. So this is what we're at a crossroads here. The endocrinologists in the community have been advising the patient to just watch this, but this gets back to, I think, what Amy was talking about earlier with respect to the interval of recurrence. This is a pretty short interval here, and now you've got a tumor where the cord has gone out. Where do you go in this 67-year-old patient with respect to treatment planning and your recommendations to he and his family? And they still can hear that surgeon saying, "Don't ever let anybody operate on you ever again." Joe?
Once again, the long discussion, there's certainly risk to not operating, so I'd kind of emphasize that to the patient family too, what the observation risk, and they've seen that already with his vocal cord being compromised. He's had a full workup of the rest of the body. I'd probably consider further surgery to discuss with this patient.
Any other takers? Would you be reluctant to go back in? Dana?
No, I try to convince them. No, that's not the way you go about it. But yeah, the for and against surgery versus observation, and patients. I mean, like you said, he's seen the how it's evolved, how it's recurring, how the voice is already bad. So that actually gives you a little leeway. You can then go in and do a shaving or do a resection of the larynx without making it really worse. And if that's the only lesion that he has, then I would say that's a good option for him.
Well, let me just come back to the imaging studies. He's got all of these areas of uptake. were significant areas of SUV. He's got multifocal disease in the neck in about 5 different locations here. What do you think? Some of those were biopsied and found to be consistent with papillary thyroid cancer. These are all new areas of disease here, but no evidence of systemic involvement. Do we send him to Jim at this point, or where do we go with the management?
I think, I mean, I would agree the surgery is probably his best option at this point, especially if there's no metastatic disease. But the surgery itself is going to be very extensive. He will likely need a laryngectomy in order to get this out completely.
Well, this is really just simply paratracheal and paraesophageal. I don't think looking at it, unfortunately, you don't have the ability to really scan through this. But I wasn't impressed that the viscera were that extensively involved here.
I'd frame the conversation as not just a surgical approach. The surgery to get rid of the gross structural disease will be important, but then I think radiation's probably going to play a role potentially for this patient. I'd have that patient seen by the radiation oncologist prior to surgery for an independent, opinion on it.
I mean, I think in this case, external beam radiation is important one way or the other. I mean, if you go ahead with surgery, then I don't know if Henning would still would say that this is the number of recurrences that they would give external beam radiotherapy afterwards, but I would recommend it. But again, if the surgeon and family decide no surgery, then I would give external beam in that situation as well.
So, yeah, Henning.
Yeah, I think I would agree on all these comments here at the panel. I think it's very difficult to say, and that this is not evidenced. How many we can put away from external beam radiation therapy with this sequential therapy? I think that would be a very interesting question to be answered. But from my experience, I would say 1/3, 2/3 of patients at the end do not need EBRT. So I think this is a patient, the operations before did another surgeon. I do not know which surgeon this was in this special case here, but of course that plays a role. And if you think that perhaps it would be good to make a real gentle but effective redo, I would do that in this patient.
Would you try to remove all of those foci?
I would try.
Yeah.
Okay.
Yeah.
And I think the other thing too, that your table that you showed several slides ago of the decreasing thyroglobulin indicates that this is undergoing dedifferentiation.
Exactly.
So it's even more important to consider surgery in this.
Okay, terrific. So this is what we found, and interestingly, we've got these various percentages of tall cell variant that were identified by the pathologist for all of these various foci of disease that were removed. We did take this right off the trachea. It did not violate. We had a microscopic margin at the level of the joint, but the rest of it, and even that submuscular plane on the esophagus, came off very smoothly. So I told this patient that I was going to be with a panel of experts today, and they were going to tell me what I should advise him. So it seems like the panel's heading towards external beam at this point. And what do you expect from a functional perspective? We're going to have to get his vocal cord medialized, but what do you expect from a functional perspective we should advise him, Jim?
I think, with careful radiation planning and IMRT, his function should still be good. I mean, I think esophageal stenosis is the main complication we see, but that's still very infrequent, and we rarely require PEGs to get patients through radiation, and I think the functional outcome should be very good.
And would you just radiate the thyroid bed, or would you radiate these multiple foci of disease as well?
I think he's at risk of other foci, so yes, I would treat an extensive volume probably. I mean, the good thing is that there's no gross disease, your margins were negative, so you don't have to push the dose very high.
Okay, all right. So let's get back to what Joe and some of the other panelists were talking about here. These are your options for management of the resected recurrent laryngeal nerve. Let's talk for just briefly here how you manage this. Do you reinnervate in the primary setting if you can, and do you do that with a nerve graft, or do you do ansa cervicalis to the distal RLN if it's obviously if it's available, or do you wait and medialize that cord in the secondary setting? Amy, do you want to touch on that?
So if preoperatively, if the vocal fold is functioning and you realize intraoperatively that you have to sacrifice the nerve, I think I would try to do a nerve graft in that setting. If the nerve is already paralyzed or the vocal fold is already paralyzed preoperatively and the nerve obviously is invaded, then I don't usually tend to do an intraposition graft in those settings.
Okay. Dana, do you do the same?
Yeah, no, usually I would do something secondarily, medialization procedures.
You would, not try to reinnervate.
No, and then you get some spontaneous recovery, some spontaneous reinnervation from other sources, the intra-artenoid muscle, and so actually functional results sometimes without anything are better than we expect. So usually I give it a little bit of time and discuss with the patient also what their expectations are. Sometimes they have really bad voice and they don't care, and they don't want any more surgery. So there's really, but I would give it a little bit of time and do something secondarily.
Joe, you and Estamos?
Yeah, my preference, especially if we've had this discussion beforehand, would be an answer to recurrent and a concomitant injection. We've actually got a very busy cardiac center, and we've published our results on answer to recurrent, and particularly in a young patient, they have some remarkable recovery in those scenarios.
So you'll inject and with a absorbable, and then wait for the nerve to reinnervate. Okay. All right. I want to get to two last cases here, and then try to open this up to the audience. 79-year-old female, recurrent papillary. 2011, she underwent a total thyroidectomy at an outside hospital, 1.5 centimeter PTC with adverse features. 2014, she had some nodes identified. They were injected with ethanol. And 2017, she underwent surgery for an apparent recurrence. Otherwise, really quite healthy, 79-year-old, very robust, and a very supportive family. Hypermetabolic focus identified at the primary recurrence and no evidence of systemic disease. And this is what her disease looks like. Her voice is normal. The surgeon had gone in. This is another one of those cases where a surgeon had gone in and found disease involving the cartilage. This very much looks like what Dr. McCafferty had identified with respect to one of the pathways of involvement here to get behind the posterior border of the thyroid ala. And so this is what we found at the time of surgery. And this is what I ended up with frozen section margins clear. And I want to explore with you, how would you manage this? I think this is either a type 1 or a type 3. Henning, which one is it?
I would do the same, the type 2. I would do the same as you did in this case. Wonderful view on the operative field.
So you would, so how would you repair this?
With SCM.
Just you'd put a patch of muscle?
Yeah.
How big does that, what's the maximum size that you would just patch with muscle?
2 centimeter.
So on the 2 centimeters, all right. I think we were pushing the limits of that. I don't have a ruler next to it. And then you
But of
would,
course, it depends on the distance to the midline
okay.
and the posterior wall. So of course, 2 centimeters is only a recommendation, perhaps.
All right. And so the other panelists, would you patch with SCM? Is that how you'd manage this, Amy?
Mm-hmm. Yes.
Okay. Dana?
Yeah.
All right. Joe?
I might, sometimes on those lateral defects, I might think about taking out more cartilage, almost like a Mohs surgery, to create a more tension-free direct anastomosis, potentially.
All right. So you would actually take this to a type 3.
Yeah, definitely.
As shown here.
Right, to expand the potential, yeah.
Yeah, so I think this is what you're suggesting, where we took out some cartilage on the opposite side and just slid the trachea up to repair that. And in this case, that actually worked extremely well. And then we put muscle over this as an SEM coverage on this. And this is what we found, and no evidence of extra nodal extension with some of the regional nodes that were also involved here. So clear margins, where do we go with this? Jim, where do you take this case here?
I mean, I think, you know, if margins are nice and clear like that and you're satisfied, you got a good, clear procedure, then I think there's no need for external beam. But I think it's a case that needs discussion because this is a recurrence. What's the likelihood of it recurring again? If you think it's high and you're not going to go back again, I mean, she's quite elderly, isn't she? I've forgotten her age now. But then I would give external beam. So I think you can make arguments both ways, really. And I think it, as said before, and I keep on saying, and perhaps it's my own fault for making you surgeons make my decisions for me. I think it really depends on what you find at the time of surgery.
All right. So one last question. I'm going to open this up before
So what did you do?
So we chose not to give external beam. We did give her radioactive iodine. Just one question. When you guys do a muscle flap and you suture that in place, do you extubate right away? Or do you wait for a period of time? Do you ever protect that with a tracheostomy tube? How do you approach that? Henning?
We would do a prolonged intubation in that case.
24 hours or even more?
At the minimum, perhaps 2-3 days.
Okay.
Depends on the length and the vascularization of the flap, because this, of course, at least from my experience, is the major component of a uneventful healing of the anastomosis, the vascularization of the flap. It's of utmost importance. So depending on that, I would indicate the duration of the prolonged intubation of the patient.
Okay. All right, we've got just a few minutes left. I want to just see if the audience has any questions that they'd like to ask our panel. Yes.
Good afternoon. Would any of you trade the management nowadays with the using of TKI inhibitors like Lenvima, like old patient, recurrent disease, invading the upper air digestive tract? Would you use Lenvima instead of doing tracheal resection and other big surgery for 80 years old woman?
Dana?
Yeah, well, that's an excellent question. And again, in the guidelines, it's really nicely stated. It's progressive disease, patients that are becoming symptomatic, where you don't have a lot of options. We have a couple of cases. They're very rare cases where patients were metastatic, but their problem was in the neck. They'd already had surgery. They'd already had external beam radiation therapy. And we've actually had some very good functional results, some good tumor shrinkage with that. The problem is bleeding, and so if you have something with that tumor that's actually invading the tracheal wall or the larynx or the esophagus, you have to be very, very prudent about using those, because you can have bleeding and you can actually have some deaths from bleeding. And then a series from Gustave Roussy, we had about like 2%. There's about a 2% problem with 1.7% problem of death from bleeding in the invasive cancer that was treated with these. So you have to be really careful with that. But if it's outside of the lumen, that might be an option, but there's not a lot of data out there.
Yep.
We have time for one last question before the noon hour is upon us. Any further comments from the panel? No,
Great
I think
cases.
we're all pushing up against other commitments. I want to thank the panel. You all were terrific.
Those are great cases.